your work. The pun here is intentional. So I'm going to talk a little bit about nutrition and so the Bytes and then also Bytes. I do a lot of work in digital health and how we can use nudges and messaging and other things to promote better uptake of some of the more precision or tailored strategies that we would like to use. So I'm going to take you on a little bit of a journey. I'm going to start with sort of the interest in this field, and this is showing you, this is ubiquitous across many different types of treatment. I'm showing you here a variety of treatments for management of obesity, lifestyle modifications, and pharmacotherapy, physical activity, and also surgical interventions. And what you can see here is across all of these types of therapies, the response to treatment is quite heterogeneous. And that's within study variability and then also between study variability. So thinking about what are the factors that would be associated with these differences. There are treatment factors. Today, we're focused a little bit more on the individual factors. So when we think about those treatment factors that I listed on the prior slide, we know that treatments vary based on the duration and intensity, the frequency of contact, the type of training the interventionists have, the prescription, which we'll talk a little bit about, the content of the intervention, and even which medication. Those are all factors that have an impact on the outcome. But there's also individual factors, and sort of the search for predictors in this particular field has been fairly non-conclusive. We have not had a lot of predictors that have been successful. So what I mean by predictors are pre-treatment factors that have predicted the success of the treatment. And, some of the better predictors are those that emerge during the treatment, and primarily adherence is one of the best and most consistent predictors of outcome. But, we're really getting much more robust samples, more diverse samples, and larger samples when we can pool across some of these interventions and move into areas where we have much more ability to perhaps look at some of these individual factors and how they could interact. So today I'm going to take you on a little bit of a journey thinking about how we could think about what we call precision public health in my laboratory and thinking about both prevention and treatment in the areas of nutrition and obesity, using these as sort of the use case to talk about some of these different topics. And so the first is personalizing the prescription. So if we could understand what type of approach would be best for an individual, we could prescribe a better or recommend better from the outset, and that might improve our outcomes. The second is once we know and we get the prescription right, we have to help people be able to adhere to that prescription. So here we might think about what supports do people need? And so in most of those prior studies I was talking about where there's between study variability, we might prescribe the same number of sessions for everyone, but person A really might be fine with only 5 sessions, and person B really needs 15 sessions to be successful. In most randomized controlled trials, though, we have a consistent dose. So the field is moving in more an adaptive methodology or approach. I'm going to talk about how we can use digital health perhaps in a more scalable way here to provide more precision support. And then thirdly, universally, we've sort of looked at predictors as if we could find the predictor. I'm going to talk a little bit just at the very end about how maybe that approach also needs to be personalized. Okay, so first off, personalizing the prescription or the recommendation. And I think one of the reasons I was invited here is to talk to you all about a very large study that you may or may not know, but you may be interested in. And that is the Nutrition for Precision Health study that is powered by the All of Us research program. So NPH, as we call it, is the first ancillary study or sub-study of the larger All of Us research initiative. And the question that we're asking here is, can a personalized diet help improve health and prevent chronic disease? So we're trying to answer this question by looking at how individuals respond to different foods. And we're doing this within the All of Us research program. So let me tell you about that if you don't know. This is the NIH's initiative to enroll about 1 million folks and to really focus on those who are underrepresented in biomedical research to create a very large and very accessible database that we can all use to try to accelerate the findings in the biomedical space. So all of us is really going on across the country, many places. You may already know, you may be joining, you may have family and friends who are part of it. There have been so far about 800,000 plus participants who have enrolled in the All of Us program, and a little over 500,000 who have completed steps to really move forward and contribute their data to the overall data set. As researchers, you might be interested in looking at the Researcher Hub. And so this is a place where there are a number of tools. You can quickly go and look at the data availability because the data coordinating centers are able to release certain data sets over time. So certain variables are available now in certain numbers, and then there's a release program that's listed here for the rollout of various data. And this particular group may be very interested in the genomic data that's in the data browser. You can be a citizen scientist and access the All of Us data. You can propose a study as a citizen scientist, as a student, and as faculty at any institution. But the idea here is that if we all are working on solving some of these problems, we can really accelerate the findings and get much better and more quick answers to some of the most pressing problems. So right now, if you're interested in the researcher workbench, there are over 400,000 survey responses. So there's lots of contextual data here, social determinants of health. Participants in All of Us also come in for physical measures, or they can self-report. Due to the pandemic, there were some folks who were self-reporting, but most people come in for physical measures at one of the clinical locations. There's over 300,000 physical measures. There's genotyping arrays. There's EHR data. So usually we try to get everyone to agree to EHR sharing, and now we're working on trying to get all of those data from the various electronic health records that folks are using. And there's Fitbit data on a smaller subset of folks. So some of the participants have been able to receive Fitbits. And then a variety of other, whole genome sequence, et cetera. So why are we interested in recruiting a subset of the All of Us participants to do a nutrition for precision health study? And I show you the prior dietary guidelines for Americans, some of the recommendations from the 2015 to 2020, the 2020 to 2025, which are our current guidelines, took a first step at trying to make more broad recommendations that were not as prescriptive, with this recognition that probably the recommendations that were much more universal are not really going to apply. So if we look at the ones from the prior guidelines, consume less than 10% of calories per day from added sugars, consume less than 10% of calories per day from saturated fats, and consume less than 2,300 milligrams per day of sodium. So these are universal recommendations that are, your recommended daily intakes that you would see on the nutrition label and other things. But more and more, what we're learning is that these sort of one-size-fits-all recommendations are not probably the direction that we need to go in order to optimize health for Americans. So the need here is that poor diet continues to be a leading cause of preventable death and disease, really associated with lots of our most pressing chronic diseases in the US, which drives healthcare costs. And the one-size-fits-all approach is not probably our best solution here. And we recognize increasingly that these interactions between what we eat, our metabolism, the metabolites, our nutritional status, our genetics, our gut health, our microbiome, and our environmental context all interact in ways that really are important for optimizing health from diet. So the purpose of the Nutrition for Precision Health study is to understand how we can tailor to a person's genes, culture, and environment to improve health. We have 2 AI data centers in the consortium. One is at West Point, led by Diana Thomas. One is at the City University of New York, led by Bruce Lee. And they are helping us to identify patterns that will allow us to predict individuals' response to food and diet. And this is also going to be added to the All of Us database so that we can leverage the larger data to create a more complete picture of different people across the US with different disease states and other things. So we're doing this in a sub-study, hopefully to leverage the much larger data there. So NPH is the first ancillary study to All of Us. It's an over $170 million initiative that the NIH has been leading. There are 15 awardees around the US. And so if you're interested in participating, your closest center may be UNC. And we have 2 locations over closer to Charlotte and also, but there's also a clinical site at UAB. And at the Pennington and others. So plenty of places to participate. So the way this study works, NPH is, again, nested within All of Us. So I'm showing you that there's the overall study. And the first module that we are doing is what we call our usual food plan. So the usual food plan is nested within All of Us. And then we have either 2 other modules, modules 2 and 3, which I'll explain in a moment, that are where we're providing food to our participants. So we're giving them the dietary patterns and having them consume them and then studying them. Those are sub-studies of the usual food plan participants. So each is a smaller N over the course. And then the third module is actually the same as the provided food plan, but folks live in. So here we have domiciled participants where we can take lots of other measures. They live with us for 2 weeks and all their food is provided. So it's a much more intensive study of a much smaller subset of folks. So across all of these, there'll be a lot of opportunity for learning. So the way it works is in module 1, we sort of in our consortium just call this our phenotyping module. So here's where we are taking the largest number, approximately about 8,000 or more. All of us participants will participate in module 1. We will examine their baseline diet for 2 weeks when they will be doing lots of measurements. So they wear a continuous glucose monitor, they have an accelerometer, they're monitoring all of their dietary intake through food photography and other methodologies to see what they normally eat over this period of time and how that impacts their glucose. On a daily basis, we are measuring their, we have fecal samples, urine samples, all kinds of samples across the period of those 2 weeks. They then come in at the end of those 2 weeks and they participate in what is called a meal challenge, where they consume a liquid meal that everyone is consuming that's the same. And it's a challenge because it's a large bolus of calories that is consumed within 10 minutes. So it's a challenge to the body. And then they have an IV placed, and over about 6 hours, both before and after the meal challenge, we're monitoring a lot of different physiological parameters as well as appetite, lots of other things. So this is our largest sample of the 8,000. In North Carolina, we're doing just over 1,000. We've just renegotiated some of our targets, and we're doing a little over 1,100 folks across our 2 sites just in North Carolina. And then in module 2, we invite a subset to come back. And this is when we are going to look at their responses to 3 different dietary patterns. And I'm going to tell you about those dietary patterns in just a minute, but they experience those for 2 weeks. And we do that same sort of set of measures that we were doing in module 1, but now with real food. So, and folks are eating this food, not their usual diet, over those 2 weeks. And then they come back in for a meal challenge. And then in module 3, it's exactly the same, but they're living in. So in North Carolina, we're doing about little over 415 in module 2. We've just upped our numbers a little bit because we have 2 metabolic kitchens, and so we can do a little bit more to help with this overall study goal of around 1,200 to 1,300 folks. We are not doing Module 3 in North Carolina. There are several sites around the country that are. The closest to us here is the Pennington Biomedical Research Center, where they're doing Module 3 and folks are domiciled. So here's just an example. Originally, this says 10,000 because we were hoping for around 10,000 folks. It's probably going to look like more than around 8,000 that we can get in the time that we have to achieve this. They're going to come in for their first visit, then they have this observation period, and then they come back for visit 2. I just show you a few of the measures that we're doing during these. And this is the same for Module 1, and then imagine this with food for Module 2. So it's very, very similar, same measures. So the diets that we're testing in Module 3 are very different than each other. If you've heard of if you heard of measures of diet quality that you can get from various diet assessment measures, these 3 diets have very different, what we would call diet quality indexes. So the first diet, which we call the blue diet, has high amounts of fruits and vegetables, whole grains, beans, moderate amounts of dairy, meat, poultry, eggs, fish, nuts, seeds, vegetable oils, and very low amounts of sugar, sweetened beverages, and desserts. So low sugar, high in many of these other kinds of foods. The purple diet has high amounts of refined grains, meat, poultry, eggs. It has sugar sweetened beverages. It has sweets, snacks, desserts, processed foods, a moderate amount of dairy, quite low in fruits and vegetables, whole grains, and fish. Not sure if anyone recognizes this type of dietary pattern, but the purple diet is that. And then the orange diet has moderate to high amounts of vegetables, meat, poultry, nuts, seeds, fats, and oils, low fruit, low dairy, and very low grains and sugars. So these 3 dietary patterns are quite different when you look at them, when they're being provided. The volume of food is also quite different across these 3 diets, and they're meant to be isocaloric. So all the participants are meant to stay weight stable during the 2-week food provision. So we are matching what we are providing with meals and snacks so that they are not gaining or losing any weight, so that we can better control the metabolic changes that we see in response to the food. Any questions about the diet? Anyway, it's been quite fun. I'll just give you a quick update. We, so far across the study, we've done about 2,800, almost 3,000 folks through Module 1 across the country. Around 300 that are either finished with Module 2 are currently in a diet phase. We're trying to finish most of the people that are on diet right now before Thanksgiving and take a little break during the holidays. The way Module 2 works is you go on diet for 2 weeks and then you have a washout period of at least 2 weeks, but it can be a couple weeks longer. And we want to finish all 3 diets within 6 months. So we work with folks if they're out of town, other things. They come back in, they pick up their food at our metabolic kitchens about every 3 days. Sometimes every 4 days. And so it's a lot of food. That's about what you can store. And then also we want it to be fresh. So some of these diets have more need for fresher foods than others, but that's the approach. So quite a lot of fun. We've served in Chapel Hill over 11,000 meals, and we've only done about not even 20 to 30% of our samples. So there's a lot of food being served out these metabolic kitchens. Okay, so I'm going to switch gears a little bit and tell you, that study, we don't have the results yet. We're going to be finished in about 1.5 years. So we'll have about 6 months to a year to get all that data analyzed for our first primary paper and then upload it into the All of Us researcher workbench. So that's kind of the timeline there if you're interested in the intersection of diet and genetics. So I'm going to switch gears and talk about optimal treatments because we're talking about sort of personalizing our recommendations. And I think about this idea that when we're thinking about things that people can do for exercise, this question is always asked about, well, what's the optimal exercise? Should I be strength training? Should I be doing aerobics? Should I be doing it 3 days a week? Should I be doing it 2 days a week? And usually the response is, well, the best exercise is the one that you will do, the one that you like, and the one that you're going to do the most often. So yes, there might be something that could help you improve your fitness slightly better, but if you don't do that, you don't enjoy it, you're not going to stick with it, it's not going to be as beneficial overall. So I think that's one thing that's important for us to keep in mind, is that we might find optimal treatments, but we might, patients might not choose to do them or to follow those. So I'm going to talk a little bit about a study that we did where we tried to think about helping patients to experience a little bit of both. And this is a pilot. We have the paper under review right now. I'll call it Mobile Personalized Weight Loss Recommendations. We called it Empower because we were trying to empower participants to be part of the decision-making about what treatment would work best for them. And in general, most preference studies have not shown a benefit of matching to preference. And so the majority of these preference studies in our area of treatment have been those that assess preference before the trial, randomize the participants to the treatment, and then see if they got matched or mismatched to their preference, how did they do? So you would assume that if you get randomized to your preference, you might do better because you think this is better for you. The problem with the way these trials have been conducted thus far is that the majority, we don't know if they really know because they haven't actually tried it yet. So it might be like asking a patient, well, which medication do you want? And they don't really know what the side effects are. They don't really know how they're going to feel. So they're kind of just making a guess. So in the study that I'm going to tell you about, we tried to give folks a chance to experience these different approaches and then make a choice at the end of an experimental period. And we had them experience 3 different factors. This study is really focused on optimizing glucose. Not going to go into all the details, but one of the factors was diet composition, either a lower carbohydrate or a lower fat. There's evidence out there that folks who have impaired glucose will do better on a lower carbohydrate, but normal glucose folks do not. They actually do better on a lower fat dietary approach. So this idea that, well, low carbs is good for everyone, not necessarily borne out so far in the literature. So we wanted to see how that would work. Meal frequency and eating occasions. We wanted to look at not priming the pump a lot. So either 3 meals, no snacks, or 3 meals and snacks for better, again, glucose regulation and also weight loss. And then exercise frequency, the same kind of thing. There's some evidence that daily exercise is helpful for better glucose regulation. But some people can be more adherent to things like having a weekly goal. So I could exercise 3 times this week and meet my goal of 150 minutes. It's really hard for me to do it every single day. I have a lot going on in my life, et cetera, et cetera. So you get the difference there. So in this study, we had folks randomized to either the personalized or the standard. Standard prescription is the same diet and exercise prescription for everyone. Try to reduce your calories, do it however you like, just meet the calorie goal. You can choose whatever foods you like and whatever combinations. Exercises, meet the 150-minute goal per week, however you like. That's kind of the drill. Everyone got phone counseling once a week, about 15 to 20 minutes every time. In the experimental condition, they had 4 weeks of experiment. They then chose their approach and they followed that for the next out to week 12. This was a 12-week pilot. So the way it would work is you would follow a macronutrient approach for 2 weeks, and then you would alternate the meals and snacks versus meals and alternate the daily versus weekly. It was randomized in what order you got, but you couldn't experience every single 3-way comparison in 4 weeks. You do the math, but this is how it would work. You would try every single meal and snack approach, every single exercise approach with the macro. So you can see that there. Some folks did low fat first, some folks did low carb first, et cetera. And at the end of each week, folks were rating their the acceptability, the feasibility, and then they were also looking over their continuous glucose monitor data with the telephone counselor, as well as their weight change data, which was collected through a wireless scale, and all of their physical activity data was collected through a Fitbit. So they had an application which helped them. You can see at the bottom of this page, if you're on meals and snacks, you see how many meals and snacks you've had. And then also, depending on your macros, you can see if your carbs and fat are where they're supposed to be. And this data was available to the telephone counselor. We screened 122 people. It was a small pilot. We randomized 3 to 1 because we wanted to try the personalized approach. We've done standard a lot. So we randomized 3 to 1 for the pilot. And we had a pretty homogeneous sample in the pilot. We also were experiencing the end of COVID, so a lot of things. Here are the weight changes over 12 weeks. So for reference, a 5% weight loss has been shown to really improve lots of physiologic parameters. Usually most remote programs are on average around that 5%. You can see that's what happened here with the standard, about 4.6% weight loss, and personalized had 7.27. And then when you look at those who lost 5%, so if we look at that as a criterion measure of health benefit, in the personalized group, 74% met that goal, and they lost 9%. So quite successful. For those who it didn't work for, it was very similar to personalized. About 50%, they didn't hit 5% in personalized, 26% in personalized did, 50% in standard did, and the weight losses were similar among those who did not. But what was really striking to us was the successful in both of the groups. You generally see, more about this 50-50 is what you generally see. So we were successful in getting in the personalized group more folks to that health beneficial level of weight loss. Obviously, we have to do this in a bigger sample. There's lots of things. Now, importantly, we had about 30% of the sample that had impaired glucose at baseline. All of them returned to normal glucose by the end of the trial, which was only 12 weeks, which was really remarkable. And the only difference we really saw in adherence was there was a slight increase in the percent of days that folks tracked their diet in personalized compared to standard. But diet, activity tracking, and daily weighing, which we collected on the SMART scale, were similar. Now, which prescriptions produced more weight loss? Well, not surprisingly, the low carbohydrate, and this is over the first, over the 2 weeks. So if you compare the 2-week weight changes in the very first period to try to see whether folks are choosing the prescription that they actually do the best on, right? So you would think, okay, you're going to try this out. You're going to choose the thing that works the best for you. Well, more people lost more weight in the first 2 weeks on low carb than low fat, on meals only than on meals and snacks. And it was about 50-50 on weekly and daily PA. Which prescriptions did they choose? A similar amount chose low carb to those that did the best. Most people chose meals and snacks despite doing better on meals. And most people chose weekly, despite some of them doing better on daily. And if we really look at that, is did the individual participant choose the 3-way prescription that they lost the most the individual prescription that they lost the most for macros? Yes, 72%, but 28% did not. For meals and snacks, no, the majority did not choose just meals because probably it's very hard for people to do that, very hard for people to stick to that, even though their glucose was better and their weight loss was better. And they chose, about the same on their physical activity goals. So I think there is some evidence here that personalized prescriptions with participant choice after experimentation resulted in better weight loss over time compared to standard. But participants did not always choose the prescription that resulted in the quote unquote best health outcomes for them. And we need larger studies to look at this approach. So I'll just quickly talk about personalizing the support with mHealth. And so this idea that once we get the prescriptions right, what supports are needed by whom and when are likely to vary. So even if we make a recommendation for lifestyle change or for following a certain protocol or for getting counseling or whatever those things are, this gap between knowledge and intention to do something and actually doing it and sticking to it is large. So crossing the knowledge to an intention to behavior gap is one of the biggest challenges we always face in this field. And there is an opportunity for mHealth here. And I know our previous speaker was talking a little bit, and I know folks are worried about the fatigue with messaging, and that is real. The data that I'm sharing with you are folks who want to receive their help this way. So the majority of folks find this kind of help and support more convenient. You know, pre-pandemic, we could get folks to come in perhaps to groups. Cannot do it anymore. People do not want to do this kind of face-to-face group treatment any longer for these kinds of problems. And most folks are online every day. 41% of adults say they're online constantly. So mHealth has an opportunity for us to reach people where they are and perhaps when they need it, and to make some quick adjustments to what we're sending and when we're sending it. So I teach a class on mHealth for behavior change. We really talk about this as an opportunity and a challenge because of those real reasons that there are so many messages that folks are bombarded with constantly, but it is the way that most people are getting their information and communicating. So it's both an opportunity and a challenge. And the opportunity here in what I see is for these just-in-time adaptive interventions. So we see this in our field as using seamless and uninterrupted collection of health information. So we're giving folks a lot of sensors, their glucose monitor, their fitness tracker, they have their scale, we have lots of data, and that we can bring that data in more often to deliver a more appropriate message than when we're asking folks to tell us and we're collecting data very infrequently. So we can decide when to build in silence, when to ignore, and when to message. And hopefully by using some of these passive data collection methods, we can reduce burden and this allows these kinds of interventions to be rapidly tailored. I call this tailoring on steroids. We've been doing tailoring for a long time. We've been thinking about marketing and tailoring messages, health messages that we send to folks for years. We started doing it in print-based interventions. I've been doing it online for 20 years. I mean, we've been doing this a lot, but we have this really unprecedented opportunity to do it much better and to do it more seamlessly and to follow a lot of the principles that marketers get really, really well. And one of the things, and I alluded to this earlier, is that we have often delivered the same intervention to folks regardless of their response patterns. And this really gives us an opportunity to treat responders and non-responders differently in terms of how intensive the intervention is, but also what messages are delivered. The frequency can be varied depending on their behavior, different user characteristics, and also the context. So this is kind of the engine that we have built. We work with time. So we have decision points throughout the day when we're gathering and looking at data to try to make a decision about whether to message or not. We have rules that include our variables with the values of those variables, and then message options, like what we might send depending on those differences. So the tailoring variables are very much those algorithms that previous speakers have talked about. We're using them here not to choose which population, but to choose which behavior, when, what context, and other things. So those algorithms are applied to determine if a message is necessary, and if so, what message. And then we focus on everyday behaviors in my space, tracking behaviors, weighing, eating behaviors, physical activity, and app usage, with the long-term outcomes of weight, health, and quality of life. So we call these just-in-time adaptive interventions, or JEDIs. And the way that these kind of look in practice is that you have multiple decision points per day. You have your behavior change engine, which is applying the decision rules, the tailoring variables, and then selecting intervention options, which for us in the digital space are messages. And then our proximal outcomes, where we analyze the effects of these, are on the daily behaviors. So we look at the impact of a message that we have sent on about the physical activity in the next hour, or the amount of physical activity attained at the end of the day, or the carbohydrate intake at the end of the day, et cetera. So we're doing these kinds of the outcomes are daily in these kinds of interventions. And then ultimately, those, hopefully, adherence to those behaviors, goal attainment improves with the messages each day. The more often people reach their goals, the better their health outcomes at the end. So that's kind of the premise. And then really, are all messages equally effective for all behaviors and for everyone? So this is a huge opportunity in this space to see what kinds of messages should we be delivering. So I just heard the previous speaker talk a lot about reminders. Reminders are one type of message, but there's many others. And we also don't know exactly when to send them. So in this model, we can use something called micro-randomization, where we know you need a message. Okay, so I've determined with the algorithm that you need a message, and I micro-randomize you to get one or not, or to get message A versus message B, and then I look at the effect on your behavior today, right? So you have much more opportunity to study many, many more things in the context of a trial than we would normally have if we have black box intervention A for 12 weeks compared to black box intervention B for 12 weeks, and then we just hope that maybe there's a difference at the end. So this is unpacking what's happening to try to give us more information about what messages are effective for whom and in what context. So I'll give you a quick example of some different message types. Over here are the type of message, like reminder versus implementation intentions. Very different. Outcome feedback, also very different. Social comparison. This is a biggie. Some people love this, some people hate this. This is a real individual difference type of message. So when you're looking at what's going to work for whom, there's a lot of differences, and it may be that it also varies by behavior. So we're learning that certain types of messages are better for promoting physical activity, and other types of messages are better for other things. So I just present this as an opportunity to kind of think about some newer methodologies in this space to uncover perhaps what kinds of messaging about testing or about other things that you care about could be studied in one of these ways. So for us, there were over 12,000 decision points for analysis. In this study, there are about 84 total days. Folks, message views were associated with weight loss, and then we've been unpacking which messages worked best for which behaviors. And then finally, the predictor variables overall, we thought, okay, I'm going to look at your physical activity this morning. And some of the things we've been doing is if I know that you're typically active at 4 p.m., looking for your physical activity in the morning and messaging you in the morning is not very useful. So that's called personalizing the timing, right? So we do that based on your behavioral patterns. When do you look at messages? When do you use your phone? What other kinds of things? Are you in a room with a lot of other Bluetooth signaling right now so that this might not be an opportunity to message you about a private behavior because you're not in a private space? All those kinds of things can be pulled in here to figure out when to message and what type of message to give. But in general, we've looked, I think, back to that beginning opening about sort of a universal predictor that's the best one. What's the best predictor we can find? And I just call your attention to this study. It was very small, but I thought it was interesting. It was done by Eric Heckler and some other colleagues, and they looked at what are the variables that are the best to predict physical activity. And then they looked at using traditional models versus using a much more individualized approach. And what they found is that the traditional models would have led to identification of the same predictors for only 5 of their 20. So about a quarter of the folks, they would have found the predictors that were the best. And they would have mismatched the predictor variables for 75% of the group. So it means that, for some people, 5 of them exercising on a weekend day was the most, or weekend activity was the best predictor, versus for others, it would have been busy and a typical weekend, or stress and weekend, or some other factors that actually were the better predictors for the individual. So this is an idea that we can find person-specific predictors. It may not be the same predictors for all of us, and kind of move in that direction. And that's where machine learning and AI, I think, are going to be very, very important. We have a laboratory. I work with Carmina Valley, Brooke Nizami, Heather Wasser, and others. We work on all of these kinds of just-in-time interventions. And a couple of the things we're doing right now, we have a factorial experiment where we're optimizing how adaptive. So if you say an intervention should change based on the person, Well, how much? How much does it have to change? And the reason this is important is because it costs more money in the programming and the testing and all the other things. It's quite expensive. Also the maintenance. So how much does the timing need to be individualized? How adaptive do the rules need to be? Do user preferences and modifying message probability? So every message we send, participants can like or dislike. It changes the probability that they get those messages again. But we don't know if that really makes a difference, that your probabilities make you more likely to engage with this intervention over time. And then I already told you kind of about the nudge study where we're looking at the different types of messages. And then we have a study looking at AI to help us select which behaviors to focus on and what cut points as opposed to our clinical judgment. So we've programmed these algorithms based on clinical judgment and prior studies, but AI may do a much better job at selecting those. So this small R21 is studying that. And then finally, we have a new innovation lab to bring generative AI into a conversation with the participant so we send the message instead of just letting the message land and have you receive this message. Let's say it was the social comparison message. It starts a conversation with you to gather contextual data and see how you felt about that and then help you come up with a plan. So it's trying to engage the participant in their care, but through a more sustainable approach. And finally, I am the interim director at the Nutrition Research Institute, which is a UNC institute on the North Carolina Research Campus, which there are 8 universities on this campus. It's on the outskirts of Charlotte. Our primary focus is on precision nutrition. We have basic scientists who do metabolomics, genomics. We have community level scientists like myself, translational scientists. We have others. So we have a whole host of faculty and staff working in this area. And our tagline is Eat Uniquely because we're looking for these kinds of dietary approaches that can be best for the individual. But because I do behavioral science research, I really think that the tagline is Treat Uniquely because it's not just what they eat, but how we help them to do that. That's really going to make a difference for human health. So, thank you.
Okay, so I think I would also propose to add a knowledge test to our agenda. Maybe during lunch today, each one of us can assess what color of our lunch is, like purple, blue, and orange, and then Dr. Tate will tell us the correct answer.
I love it. We will look at the lunch contents and make a decision.
Oh, sorry.
Thank you very much for a wonderful talk. My name is Alex Alexienko. I'm in public health sciences and biomedical informatics, and I'm the All of Us research champion here, and obviously a champion also for the lifestyle medicine, which you seem to be one of the prominent researchers in. And I had questions about two questions about continuous glucose monitoring. One is I noticed that there's 2 periods of continuous glucose monitoring in your protocol in the Nutrition for Precision Health. And is that related to sort of the placement bias that a lot of users, I know for sure that a lot of users don't know how to correctly install them. I have bruises to prove that. Is that kind of related to that, or how do you use that?
So in NPH, I may not have clarified this. So during the 2 weeks and during all of the diet periods, they're wearing the continuous glucose monitor. So they wear it for the 2 weeks prior to the liquid meal test and during. And then they wear it, so it's 10 days because we're using the Dexcom, but and then they do it during the meal test as well. And so we put it on like in day 3 or something so that they can wear it all the way through to the meal test at the end. The placement is standardized, so most folks are asked to wear it on the stomach. However, if they can't, then there's a change to protocol that's noted and they wear it on the arm. So some people can't wear it on the stomach. But the recommendation for the Dexcom is to wear it there.
And these are self-installed?
No, we do it for them. We do it for them. Yeah. When they come in to pick up their food or they have a visit to put it on. Yeah.
And then a related question. So continuous glucose monitoring allows you to assess the glucose level and therefore glucose utilization by the body. But what about fat oxidation? Is there an effective way to measure that? Maybe not continuously, but at least somehow.
In module 3. So the domiciled is getting at many, many more of those kinds of measures when they're living in for those each 2-week period. So we have other measures in module 3 to get at some of those factors.
And have you considered the Lumen device for this, or you
We're
don't?
not, I mean, no. I mean, we have, but we aren't using it in NPH.
And is this sort of just because you couldn't do it, or because you don't trust the science behind this? I'm just learning here.
We had to make a lot of choices because the protocol was getting very hard. It's a very difficult protocol for both the staff and the participants. So we had to do a lot to kind of pare down. We had a huge wish list initially, and then some of those things we had to, yeah.
Thank you so much.
Yeah, of course.
So I think next section will highlight work done by our future leaders in precision health. So the lightning talks will be presented by Diana and Grace. I also want to make sure Anna, right? So Anna has a poster presentation. So I encourage everyone